My name is Fred Trotter. I'm a healthcare data journalist with CareSet, and we look at Medicare data and, in general, anything to do with patient data that has implications to patients' rights. As a result, we've gotten involved and are helping with this year's Datapalooza stream in order to allow, especially patients who can't make it to the conference, to have some idea of what's happening at the conference. We had ambitious plans this year to get dozens of different amazing authors and people to come and join the stream, and a lot of those fell through. However, an old friend of mine did me the favor of allowing not only for her to be interviewed at Datapalooza, but to do it early. So I'm recording this Saturday before Datapalooza, and I would like to introduce to you my old friend, Dr. Elizabeth Chiarello. I will call her Liz sometimes because that's how I've known her for more than 20 years. And I'm going to let her introduce herself, but she's released a new book, the data news that I think is really significant for the Datapalooza community to understand is that this book, Policing Patients, is actually coming out on the day of the conference. So you can pre-order it as of when I'm recording this, but you can actually go to Amazon and press buy, and you should. If you are an opioid researcher, if you are a pain patient, if you are anyone who cares about the overdose crisis, this is, I think, one of the best books I've ever read on it. Before I get into why I think the book is amazing, and I do think the book is amazing, Dr. Chiarello, can you please tell me who you are and how you came to be researching these topics?
Absolutely. Well, hello, Fred. It's so good to see you. And also hello to your audience at Datapalooza. I'm Liz Chiarello. I am a professor of sociology at St. Louis University. And I'm a medical sociologist and a socio-legal scholar. So I do work at the intersection of healthcare and law. And I've done some work on reproductive rights. And then most of my work has been on opioids. For the last 15 years, I've been studying the opioid crisis. And so this book is the culmination of 15 years of work, and I'm really excited to share it with you.
So first, let me apologize. Liz, I've only read half your book. I made time and reserved time to read the whole thing. But in fairness to me, I was not able to read quickly. Normally, I could just blast through a book. But this book is so meaty and has so many different things in it. And let me compliment you. I think it is the best book of the half dozen or so opioid crisis books that I have read, because I think it is the first book that really comprehensively lists out the perspective on the opioid crisis, not merely from the perspective of the physicians who are prescribing or the patients who were potentially abusing drugs or potentially pain patients, or patients can be melded between those two things, can be a lot of both, or the pharmacists or the pharmaceutical companies or law enforcement. And I think one of the central points of the book is that the prescribing monitoring, prescription monitoring programs.
Prescription drug monitoring programs, PDMPs.
Which are slightly named, they're implemented on a state basis. So for instance, Texas Prescription Monitoring Program doesn't have the D in it. And some don't even use that acronym at all. Anyways, my point is that you've researched these really, really carefully. And I think the reason why this is news and really relevant for the Datapalooza audience is that you are not merely exploring it from all these different perspectives, which I don't think has been done before and is excellent. But you are also bringing up issues in AI. You're bringing up patient data rights. You are talking about big data and how that's been deployed potentially against patients. You're also talking about the opioid crisis in general. I don't think I have seen that kind of double nexus ever before. And I just have, I'm thumbing my way through the book right now, and there's just every 2 pages I'm writing wow and big star and all this kind of stuff. So take me, if you don't mind, take me back. I've known you for a long time, and you just told me that 2009, you had not started this research.
I had barely started this research.
Barely started this research. All right, let's call it 2008.
Yeah.
2008, Elizabeth Chiarello. I asked the question to, is the data that is in a pharmacy or being pumped into a pharmacy or pulled out of a pharmacy benefiting patients as its primary objective? If you ask me that question, um, even 2 months ago, because we've talked about your research before, but not like this, I would have said 80% yes. What would you have said in 2008?
Well, I want to hit on a couple of things. So, first of all, your point about the fact that this book brings together so many different perspectives is really well received. And I think the way I always think about it is in terms of Chimamanda Ngozi Adichie's TED Talk. She talks about the danger of a single story. And she says it really matters where you start a story, where you end a story, who you involve in the story. And the danger in the single story is telling the wrong story. And the danger for people who care about health and healthcare is that if we tell ourselves the wrong story, we arrive at the wrong solution. And we have been telling ourselves the same story about the opioid crisis again and again and again. And that story is the story of an evil drug company that hoodwinked doctors into prescribing its very dangerous product and then hooked a nation. And, 20 years later, we had big lawsuits that tried to claw some of that money back. But if that's the entire story that we tell, we really leave a lot out. We leave out the last 100 years of drug policy in which a pendulum has been swinging between the criminalization and the medicalization of pain and addiction. We leave out the hospice movement and the pain management movement that directly preceded the release of OxyContin. We leave out what's happening now when we've had this real clampdown on opioid prescribing and what's happening to pain patients and people who have substance use disorders in the aftermath. And so we love telling the story that has a very clear villain and very clear victims. And I'm certainly not saying that story is not true. Purdue did all the bad things. Purdue and all of its, all these other drug companies did all of the bad things that people have said that they do. There's a lot of good investigative journalism on what those companies did. And a lot of people were harmed. We've lost over 1 million people to overdose in the last 25 years. It's atrocious. This is the worst drug crisis we have ever seen in our country's history. But to attribute all of that to a drug alone or a set of drugs alone is to look very narrowly at what causes social problems. And as a sociologist, I urge us to look much more broadly at social systems and to think about the broader structures that shape how healthcare providers make decisions, the organizations in which they practice, the legal and enforcement environment in which they practice, and how all of that shapes their interactions with patients and the kinds of access to care that patients get. And that is the bigger story that we have to tell ourselves. Because if we don't, we put our blinders on and we're like, oh no, prescription opioids are killing people. And then we're like, oh no, wait, it's heroin. Oh God, it's fentanyl. Oh no, xylazine, right? But all of these things are connected, and not just across these drugs, but also across pain and addiction. And so we have to tell the bigger story so we can come up with better solutions. So to your point about data, back in 2008, I'm trying to remember when the electronic health records really took off. And I believe those took off with the Affordable Care Act. So that was, electronic health records weren't even fully a thing. Most doctors were still using paper or were using their own individual self-contained record-keeping systems. And so if you had asked me in 2008, is patient data helping patients? I would think, well, yes, there's something good about having data all in one place, or even creating electronic copies of data. That seems like a really good thing, because when a doctor has a chart that they then have to copy and send to another doctor to share health information, my goodness, that slows the process. So I would think, yes, if you could communicate that through computers, if you could compile a patient file that's easy to move from doctor's office to doctor's office, that's a great thing. But I would not have predicted the way that our electronic data has been operating today and what I found in my research.
Dr. Chiarello, 2004. What would you summarize based on all your research? What would you summarize right now is the data that's in a pharmacy that goes into it, that goes out of the pharmacy? on balance, is it helping patients?
It's interesting. I mean, I'm hesitant to assign a moral valence to the data,
Or you
right?
gotta give me like a letter grade.
A
Like just
letter
in
grade.
general, like 20% good, 80% bad. What is it, do you think? Because I can, like, in the bad old days before, right? I can take a piece of paper in. It's got a signature of the doctor. Presumably the pharmacist knows the signature of the local doctor, or can call the doctor and say, "Hey, is this real?" Uh, there's information there, but it's kind of trapped, right? It's not able to move around. So when we upgrade to that data moving around, on balance, is that good for patients?
I think one thing that was very different in the pharmacy in 2004 compared to today is what I think of as the problem of the third party. So there are a lot of third parties involved in health data today that never existed before. And so the data you're talking about, the prescription, the literal physical paper prescription that went from the doctor to the patient to the pharmacy, and then the pharmacist kept on file, was between those three actors and the insurance company who needed to pay for that prescription. But those were really the actors that were involved in dealing with that kind of health data. Today, there are a lot of different organizations who have an interest in that data. So for example, the prescription drug monitoring programs that I study are held by a private company. It's called Bamboo Health. It used to be called Apris Health. And they are the ones who compile all of the controlled substances prescriptions in a state and across states, and then feed that information back to healthcare providers and to enforcement agents who can use it in a variety of ways. And so we didn't have those organizations in the mix the way that we have them today. And we don't have so many companies that have formed out of this tech explosion um, trying to get their hands on our private health data. And so I think that's really significantly different. And so in terms of was it helping us, I think to the extent that you have a doctor, a pharmacist, and a payer surrounding the patient, and the payer is a little bit complicated, but you have those three people surrounding the patient and the information, that's a very different space than when you have private companies that are looking to profit off of that data. I think that complicates the relationship between the provider and the patient, and both of those groups' relationship to health.
Just because you started talking about the myths, and I know, forgive my audience, we're skipping around. Um, Myth number one: Oxycontin kicked off the opioid crisis. Fact number one: the opioid crisis is more than a century old. Elaborate, please.
So to really understand what happened when OxyContin came out in 1996, you have to go all the way back to the turn of the 20th century. And you have to understand how opioids were used around that time. So it was really popular in the late 1800s into the early 1900s for middle class housewives to take opium. They were opium eaters. They ate it, and their doctors prescribed it. And there was really no public outcry about that use of drug. It was not until Chinese men came over to the United States to build the railroad, and they came over without their wives and without their children because they were excluded from the opportunities. And so they came over by themselves. And these men were opioid smokers and or opium smokers. It was actual opium. And so that's when you start to see a lot of these really xenophobic myths that arise around drugs. So, I mean, it's horrifying for me to even repeat them, but these ideas that, these Chinese men were going to lure virginal white women into opium dens and take advantage of them and corrupt them. And so we see a big outcry around opium at that time. And then the United States adopted our first drug law. It's called the Harrison Narcotics Tax Act in 1914. And what it did was it required all doctors and pharmacists who provided opioids to register with the state. And that's not a big deal. You're just registering with the state. But what happened 5 years later was that there were these big Supreme Court cases that made it illegal to, and again, we'd never use this language today, but they used it then, quote unquote, maintain an addict. We don't use that language because we don't call people addicts, right? We call them people with substance use disorders. But when that happened, there were thousands of arrests of physicians and pharmacists who had been providing people opioids to prevent them from going into withdrawal. And that process then led to about a 50-year chilling effect where doctors were largely unwilling to provide opioids for almost any reason. It was very, very constrained. And that was part of what prompted the hospice movement in England in the 80s, where they said, look, you won't even give opium or morphine to people who are dying in pain. You're worried that people at the end of their lives are going to get addicted to these drugs. And so they rose. And then the pain management movement in the United States rose on their heels in the 1990s. And they said, not only should people not have to die in pain, they shouldn't have to live in pain either. And so that really set the stage for Oxycontin to become a blockbuster drug. But in many ways, the high rates of prescribing that we saw immediately after Oxycontin came out was a corrective to the underprescribing that had happened for about a 50 or 60-year period. So we have to understand that history so that we don't just think, oh my gosh, this incredibly addictive drug came onto the market and it changed all of our lives. We have a 100-year period where not only have we toggled between criminalization and medicalization, but also where the criminalization of drugs has been a mechanism of criminalizing minority groups. And so we saw that with the Chinese and opium. We saw it with Mexicans and marijuana. We saw it with African Americans and crack. So again and again, it's a way of criminalizing groups. And the bottom line, I can say as a sociologist and a drug researcher, is drugs alone are not that powerful. Drugs are social and they're contextual and they're political. And so we have to be really careful how much power we assign to any given drug. I'm not saying that opioids are not powerful drugs, but I am saying that the majority of people who use them do not have a substance use disorder. And so we really need to look.
Which I think calls for precisely the type of research that you are doing, which is to say, this is a systemic problem with a lot of moving parts across a lot of different systems that are interacting. And if you research only one of them, right, you're going to make policy changes based on what only law enforcement says, or only pharmacists say, or even only what patients say. You are going to create a lot of unintended consequences in this, fabric of very interlocking systems that are really working in different ways. I don't know when this is a good time to see us, but my company makes money selling healthcare data, and we sell to pharmaceutical companies. We also have, a set of ethical standards that we operate at the company, and one of the central ones is we have to be certain that the medication that we are marketing or help marketing for a pharmaceutical company is helpful, which is an easy bar in most circumstances, because when the FDA approves a medication, they are saying it does look like it is at least better than a placebo for treating whatever it is. And then the drug company, for better or worse, has to go make that case again to all the physicians in the country. But this case that was made by Purdue with Oxy wasn't the first time, not even since then, that the case has been made by the pharmaceutical industry. We got a new pill, and the new pill is less addictive than the old stuff. That was the Vicodin. Back in the day, was marketed the same way, and tramadol now is marketed the same way. And tramadol is, in fact, better in terms of its addiction capacity than Oxy.
Fred, heroin was the less addictive morphine. I mean, yes, this has been going on for over 100 years. We keep thinking, okay, we're going to find the less addictive version.
Is this constant patterns. And so the policy at my company, and this is the only one we have like this, there's no other category of medication, but we will not assist a drug company in marketing a new opioid, even if they have strong evidence that it is not addictive, because that case has been made and shown false so many times. And it is so glaring an exception to the basic idea that new drugs are good for patients that's the one thing we won't touch. And it's interesting because it's literally the only formal policy we have on the matter at CareSet. And maybe that will change. I mean, there might be something that would overturn that policy in the future, but I kind of doubt it. Reading your book, it doesn't look like it's a good landscape.
Two quick notes on that point. So first of all, when we think about drugs, I think it's important to consider the fact that newer is not always better. It's fascinating having talked to pharmacists for as long as I have, and they'll say, look, there is this new drug, and all this new drug is this old drug that's gone generic and this other old drug that's gone generic, and they're combined in some new way, in some new formulation where I can't just substitute, the old drug and the old drug, but now it's on patent and you can charge a pretty penny for it. And a lot of our old drugs work really, really well. And we don't use them for a variety of reasons, but one of the reasons we don't use them is because they are not profitable. And so I think that's something that we should be concerned about. And then the other problem, really gets into questions about regulation and how we want regulation to operate. And the challenge with an organization like the FDA, who's approving drugs, is that they are not doing their own research. It's the honor system. It's the honor system for drug companies. And so they are presenting to the FDA a set of data that says, look, our drug is better than the placebo. But the FDA kind of has to trust them. And then later, when we find out that that wasn't true, that's when we start to see things like drug recalls rather. But certainly the FDA was complicit in helping OxyContin to become a blockbuster drug. I mean, they did let them label it as a less addictive drug than other opioids based on very, very shoddy evidence. I mean, a letter to the editor. Come on.
Yeah.
Yes, but that's how the FDA works in general, right? I mean, they did, they put their hand on the balance, or the hand on the lever, whatever the term is that I'm thinking of. They kind of, yes, they tipped the scale. They tipped the scale in Purdue's favor. But that is generally how the FDA works. And if we want to make sure that our drugs are safe, we might think about who would the watchdogs be? Who else could get access to the data before we put drugs on the market to make sure that they're actually safe?
Yeah, tipping the scale is a good metaphor. And Liz and I have a long history of mixing our metaphors and enjoying our metaphors and
finishing each other's sentences. And,
exactly.
Yeah, all the stuff.
To go to another metaphor that you used, myth number 2, bad apple doctors are to blame. That's all I'm going to say. I'm going to let you talk now.
That's all you're going to say. Oh my goodness. So doctors have been raked over the coals in the opioid crisis, and they've been called drug dealers in white coats, and they have really been spotlighted as one of the key causes of the opioid crisis. Now, there's a whole mix of doctors out there, and a lot of doctors were listening to what drug companies had to say and were prescribing based on that. And if what the drug companies were saying was true, that would have been pretty astounding. I mean, here is a less addictive opioid that you can prescribe to your patients. And not only that, I mean, the beauty of OxyContin, and again, please know, I am not an apologist for Purdue. They did a lot of really bad things, but we have to acknowledge that there also were some benefits to OxyContin specifically as a product. And the biggest benefit is that OxyContin is only oxycodone. It's only the opioid. And so a lot of the other opioids are actually combined products. They have things like acetaminophen in them, which if you take them at very high doses, damage your organs. And so if you have a chronic pain patient and they're going to be on opioids long-term and they need the pain relief effect,
over to something that's pure.
You need something that's pure and you need something that's in a high dose. And so that was the gap that OxyContin filled. And so if it were true that you could give somebody that was something that was a pure drug in a high dose that was non-addictive, my goodness, you have found the Holy Grail. And they had the FDA approval to show it. They had the label that showed it. Certainly doctors could have been skeptical knowing what we know about the last 100 years of opioids, but most doctors don't know what we know about the last 100 years of opioids. When in medical school are they hearing that story? And so we can't let them off the hook. And there were certainly some very terrible doctors out there. I mean, and there are terrible doctors in the book. You'll read about them in the book. One glaring example is the doctor who was fooled by the dog x-ray. So one of the strategies that law enforcement would use is they would send an undercover in. This was in California. They'd send an undercover officer in, and he said, "Oh, doc, I really have some problems with my back. Here's my X-ray." And the doctor would look at the X-ray and say, "Oh yes, I can see why your low back is really hurting." And Fred, you and I, who do not have medical training, formal medical training anyway, we could look at this X-ray and say, "That's a dog, that's a tail." But this doctor was like, "Oh, this is no problem," and then prescribed this officer very, very high doses of opioids. And there's a similar story in the book about a cat MRI where the name had changed, but it says feline on the MRI. And the doctor was like, "Oh yes, here are your opioids." So there were doctors who were storing opioids in the ceiling of their office, who were selling opioids out of the trunk of their car. I mean, there were some really, really bad doctors out there. But there were also some really good doctors out there who were working in a shifting legal space. And doctors are inherently conservative. And I don't mean politically conservative. I just mean they're conservative in that they want to be practicing within the standards of practice, within the norms of their profession. And so anything that goes beyond the norm starts to feel very scary to them. So the norms shifted towards everybody's handing out opioids. And not only is everybody handing it out, you are being graded on how well you are treating your patient's pain. I mean, pain was the fifth vital sign. They were really pushing doctors in that direction. Well, now the pendulum has swung so far back that doctors are afraid to prescribe, even a handful of their patients opioids. So we don't want to overprescribe and we don't want to underprescribe. We want to right size opioid prescribing. And that's where we need to get to, but we are not there yet. And we are not even heading in that direction.
So, Liz, I'll have to admit, this is another area where I have not gotten my act together. If I had a green screen set up behind me, I would want to show your chart, this chart here. I'm going to try to get it in the middle of my screen for a second. Just showing some trends. And maybe it's better. Maybe I could just say, hey, if you want to see the chart, go buy the book, which is the right answer, right?
That's a good marketing strategy, Fred. Marketing. I support it.
Sounds good. But one of the things that I think is talking about here in general is the pattern of tightening clamps on the drug prescribing, and yet the opioid deaths continue to go up. Can you discuss that problematic trend?
Absolutely. So, because we have told ourselves a single story, and that single story is that the opioid crisis started in the healthcare system, we think the solution lies in the healthcare system too. So if the problem is that doctors overprescribed Oxycontin and other powerful opioids, then the solution is to get doctors to stop prescribing Oxycontin and other powerful opioids, which makes perfect sense if that's the story that you tell yourself. But the problem is that addiction is far more complicated. The vast majority of people who are on prescription opioids do not have a substance use disorder. And so taking the medications away from those people does not actually help. But the other piece is that having the pharmaceutical supply created a sort of safe supply for people who had substance use disorders. And as soon as we clamped down on that supply, those people then were left to turn to the streets. And we have the most toxic drug supply that we've seen certainly since the late 1800s, but possibly ever. And so it's basically Russian roulette. You take something that looks like a pill that could be a Percocet, but is really fentanyl, and you are fentanyl naive, that increases the likelihood that you're going to overdose. So the other chart that's on that same page shows the three waves of the opioid crisis. So the first wave was prescription opioids. And then we had a few years, maybe 3 years, when heroin really started to take off. And then fentanyl completely took off. And it's important, I think, for your audience, and most of your audience probably knows this, but we're not talking about prescription fentanyl. We are talking about illegal fentanyl, and those are different things. So fentanyl is a prescription product. It comes in a patch. It used to come in a lollipop. And people take it for pain. It's a very powerful pain reliever. But the illegal version of fentanyl is a different kind of thing. And that's really what people are dying from today. And we're increasingly seeing xylazine, which is a drug that causes some really horrific looking abscesses. And so the very nature of this crisis is changing.
Is that the one?
Crocodile, that's a different one.
That's a different one.
That's a different one. Listen, there are too many drugs to keep up with. And that's why we can't look at each drug individually. We have to look at the broader scope of drug trends over a longer period. But anyway, so basically, opioid prescribing went like this and went like this. So we're actually at a lower rate than we were when the crisis started in terms of prescribing. In terms of overdose, it goes like this. And most of this is fentanyl. And so we are not going to stop people from using illegal fentanyl by denying them access to prescription opioids. That's not how that works. And in fact, when you turn people away from the healthcare system, it's not as if their pain goes away. So you leave them with very few alternatives. And so some of those people turn to street drugs. Some of those people buy pills off of people who have the prescription drug. And tragically, some of those people die by suicide. And so we're actually creating worse problems by clamping down on the healthcare system. And so we actually need to find better strategies. And what was so troubling to me in this research is I was watching healthcare providers push people out of the healthcare system and leave them to fend for themselves. When I think if a healthcare system is operating well, they are pulling those people deeper into the healthcare system where they actually have solutions to treat. But that's the other problem is that both addiction and chronic pain are what sociologists would think of as incompletely medicalized. We kind of talk about them as if they're healthcare problems. There's kind of ostensibly a set of healthcare solutions, but we don't actually treat them as if they were healthcare problems. And that's why it's so easy to push those people out of the healthcare system and leave them incredibly vulnerable.
And creates a situation where we are treating them like criminals, but talking about them in a medical language that's not designed to help them, but make us feel better about the fact that we're criminalizing. It's the worst of all worlds.
Yeah.
So let's talk more about this pinching situation that a patient gets in, because I learned some things that I was surprised by in your book about the, not just, I guess, the pinch that we've talked a little bit about the pinch that a physician is in with the expectations to either being penalized for prescribing too little, being penalized for prescribing too much opioid. One of the things that you found out when you were talking to the pharmacists is that there are cases where a pharmacist will turn away a person who is in the database as a drug seeker, or that they have other evidence to suspect is a drug seeker, not by saying you're in this database listed as a drug seeker, you have a problem because you're in that database, but rather by saying I'm out of oxy or I'm out of this medication. And that creates a kind of double pinch, right? The pharmacist is in a really uncomfortable position. But boy, what the patient experience is, oh my God, every pharmacy in this town has a shortage of opioids. Can you talk more about that and that pinching place?
It's fascinating because we've practically gone full circle with that. So pharmacists, first of all, are the ultimate gatekeepers to pharmaceuticals. They are incredibly important. And I bring that up because when I first told people that I was studying pharmacist discretion, people laughed at me because they were like, pharmacists have discretion? Don't pharmacists just do whatever it is the doctor tells them to do? And my research told me no. In fact, pharmacists have the right to refuse to dispense medications that they think are problematic. Now, the grounds upon which they can make those decisions are different across states and they vary over time. So some states have a conscience clause that allows pharmacists to opt out of providing drugs they morally oppose. A lot of those came up during the fight over emergency contraception in like 2006. But for medical reasons, pharmacists are always allowed to refuse to dispense something that they think is inappropriate. Pharmacists practice under their own pharmacy license. They're accountable to their own professional board. And so they actually have an incredible amount of power when they're making decisions about medications, because it's not the physician who ultimately decides whether you get access to the treatment. It is the pharmacist. They are the person who has to put the pills in the bag and hand it over to you. And if they refuse to do that, then you're in a really tough position as a patient. So historically, pharmacists made decisions about providing opioids based on things like how the patient looked and how the patient acted when they walked into the pharmacy. So pharmacists would tell me they come in, they can see my name tag or they see my name over the, over the counter. And they're like, oh, hi, Fred, how are you doing? And they're like really, really chatty and they want to chat me up and they want to know how I'm doing. I'm like, what is happening with you? Like, this is not normal behavior. Most people drop off their prescription, they go wander around the store, they don't want to chat with the pharmacist. And so behavior, the way they look, and more than anything, pharmacists told me, they would just get a gut feeling. Like when somebody walked in the door, they just got a gut feeling and they knew that something wasn't right. They didn't know exactly what. Now, was that gut feeling discrimination or was that gut feeling like just really good intuition? We don't know. We'll never know. But then they didn't want to confront the patient and say, look, I think you're overusing this prescription. You've lost your prescription 3 times in the last month, or you've gotten robbed 3 times in the last, that's a lot of losing your prescription. They didn't want to get into it. And so an easy way to get rid of that patient is to say, this medication is out of stock. Because the patient has no way of knowing. If the pharmacist says it's out of stock, it's out of stock, even if it's behind the pharmacy counter. And so then that leaves the pharmacist to go somewhere else or come back later. The PDMP actually started to interrupt that process because now, instead of relying on a gut feeling, pharmacists have data. They can look up patterns of behavior and they can say to the patient, look, you've gone to 3 different doctors in the last 2 months. You've gotten 3 different prescriptions and you went to the emergency department. I'm not comfortable dispensing this to you. And that does a couple of things. First, it says to the patient, I'm watching you. I have this surveillance system. I've used it. I can see your patterns of action. But it also discourages them from coming back. If it's out of stock, they're just going to come back later and say, okay, is it in stock now? But if they say, look, I am monitoring you and you are behaving in a really problematic way, you're disinclined to come back. And the irony of that is that now when they send those patients away, the patients then are getting, if they're able to get their medications, they're getting them from a different pharmacy. And we don't know exactly what goes into the risk score that's part of the PDMP algorithm. But certainly we can reasonably anticipate that going to more than one physician and going to more than one pharmacy is part of that risk score because it's a red flag as understood by the DEA. So we would expect that to be in that system. Okay, so now you've been turned away and now you are looking like a bad actor because of the actions you've taken after you were turned away. So do you see how this just creates a really vicious cycle?
No, it creates a vicious cycle, and it goes back to, I think, what is going to become a kind of crisis in the healthcare system, which is where you have an algorithm or an AI or something that is a big data system that is looking at partial data. In your book, you call it your double.
That was your data double or your digital double.
Idea that you have this picture of you that's not an accurate picture. It's a different thing altogether. It's not Fred. It's the record you have on Fred. You really highlight it in a different way, but this is a classic false positive, false negative situation. And if I am a patient in the healthcare system and I am diagnosed with AIDS, I will be treated differently than if I don't have that diagnosis. And it is absolutely possible for someone to go in and accidentally somebody's logged into the wrong record at the wrong time to say this person is HIV positive when they are not, or they have an allergy that they don't, or they miss an allergy, right? And so when a patient record is wrong and it starts to move around because of health information exchange of any kind, right? It could be medical billing, it can be the health information, or it could be one of these PDMPs. What I had understood to be the case is that the check and balance is the HIPAA ability of a patient to make modifications to their record by appending it. So there's a tension, right? Because if I believe that I don't have HIV and that's a mistake, and I go to the doctor, I can't just change the record because maybe I am a person who does have, in fact, HIV, and I'm trying to scrub my record of something that is a fact. And that would be a problem, a different kind of problem. So what the balancing that HIPAA did say, well, you have the right to amend your record. So if I go amend, like add a note that's essentially, well, this is what the patient has to say, and I say, wait a minute, I don't have HIV, well, then that creates kind of a crisis in the medical record that the physician has to resolve. It's like, okay, come back in for another test. You come back in for another test, and we'll look at that test. And if you are in fact HIV negative, then I'll change my record. But if that amended, saying two different things record is there, and that reconciliation process, which is a lot more complicated than you might think of at first, right? Because you don't have the right to change your record under HIPAA, but you do have the right to get access to know what it is, and you have the right to amend to it, which creates this tension. But from what you've seen in our document in the book, this is not the case with these PDPs, at least generally. And I did look it up. It looks like Texas has a way that you can log in and see what it is. But from what I can tell, just by looking at these websites, I don't see a way for patients to log in and get access to their record, to know what's in it, or to do an amendment, which are these fundamental rights of HIPAA that are supposed to bring kind of balance to this health information exchange and make it safe. Am I missing something here, or tell me more?
This takes me a little bit out of my depth. So I can't tell you too many specifics about exactly how it works. What I can tell you is that the PDMP record is not like your credit score. And it's not the way you just described under HIPAA where you're making the amendment. There might be some process by which you can amend your PDMP. But first of all, you have to know that that record exists. And then second, you have to know what the process is to try to amend it. And because the PDMP is not covered under HIPAA, I don't know that the HIPAA privacy amendment rights apply.
It's because and I think you talk about this more explicitly, so let's go back to the stuff you know a lot about. It is because there is a carve out from HIPAA. HIPAA does not apply to law enforcement. Law enforcement has a right to get access to your record, and a person with a HIPAA covered record has to cooperate with law enforcement. It's part of what HIPAA says. So it's not so much that they are not HIPAA covered. HIPAA does discuss law enforcement, and it kind of gives them a blank check. Now what you're saying is they're using this blank check as law enforcement, which talks to, and I think this is, again, to bring it back to your expertise, this is a hand-in-glove relationship between law enforcement and clinicians, physicians, and pharmacists. And what is confusing to me is I don't know which one is the hand and which one is the glove. Certainly very close. But it seems to me that this is a policing, and it's the patients are being policed, it's the pharmacists that are being policed, and it's the physicians that are being policed. Even though when you look at it that way, it's like, why is it in the interest of any of these three groups to be cooperating with law enforcement in that way? Because I am looking at these PDMP websites. I can make a complaint about my provider. I can report that my provider is prescribing in a way that is problematic. So this seems like it's hey, let's all turn in our buddies, or turn in the people we don't like over to law enforcement around something that would otherwise be a medical process.
Well, and that's part of what I think is so fascinating about these technologies. And this is why I call them Trojan horse technologies. So if you think back to the Trojan horse story, which many of us read in high school, the Trojans were horse people. It was kind of their thing. And so that's part of why, when they open their gates and there's this huge wooden horse sitting there, they think, of course, what better symbol to commemorate our victory than this enormous wooden horse? But what they didn't expect was when they rolled it through the gates, was that hiding inside were Greeks who wanted to kill them. And kill them they did. They snuck out in the middle of the night. They snuck out of the horse. They slaughtered them, and they snatched victory from the jaws of defeat. And so PDMPs work the same way, but without all of the death and destruction. Instead, healthcare, they're healthcare people, they're documents people. They had just implemented the electronic health record, and the PDMP looks like an electronic health record. It has a lot of the same trappings as the electronic health record. But what healthcare leaders did not anticipate when they wheeled this system behind healthcare's walls was that lurking inside were enforcement logics that would change the very heart of healthcare. And so what I show in the book is that physicians use PDMPs in conjunction with a set of other enforcement tools. So things we normally think about parole officers doing and not really think about healthcare providers doing. So for example, physicians use the PDMP alongside pain contracts, which are these legalistic documents that say things like, you're only going to see me, I'm your only doctor, you are only going to go to one pharmacy, you are not going to go to the emergency department looking for opioids. If anyone else prescribes you an opioid, you're going to tell me. I am going to test your urine at random when I want to make sure that A, you're not taking anything other than what I've prescribed, but also B, that you're taking what I've prescribed so that I'm sure that you're not selling this drug on the street. I'm going to check you in this big data surveillance system, the PDMP. And as long as you can follow all of these rules to the T, then I'm going to prescribe you opioids. And if you fail, I'm going to dismiss you within 30 days. I'll give you one last prescription and then you're on your own. So we don't really expect patients to be treated that way. And then meanwhile, pharmacists who started using the PDMP, I talked to them in 2009, and then I talked to them for a decade. And what I noticed once they started using the PDMP was that their routines, their relationships, their roles all changed. So they really started to behave quite differently. They started to act more like law enforcement once they had access to the PDMP. Their relationships to physicians changed. They're historically, they are lower in the medical hierarchy, much lower in the medical hierarchy than physicians are. The PDMP gave them power because it gave them information that physicians either weren't accessing or hadn't fully processed. They got closer to law enforcement. I heard from both pharmacists and from law enforcement that pharmacists would call law enforcement and say, hey, there's something going on with this patient, or hey, there's something going on with this doctor, which goes to what you were saying about this, like reporting the people that we don't like or we think are behaving badly. And then they start talking about themselves very differently. When I started their roles, when I started this research, pharmacists commonly said to me, I am a healthcare provider. I am not a detective. I am not a cop. That's not my job. My job is healthcare. And so the way I talk about it in the book and in earlier pieces is they thought about themselves as medical gatekeepers, and they thought they were being asked to be legal gatekeepers, and they were uncomfortable with that. By the time the PDMP comes along, suddenly these roles are melded into one. So they're telling me things like, I say to them, the things that you're doing, a critic would say, that these things that you're doing look a lot like what cops do. Do you think about this as policing, or do you think about this as something else? And they say, no, it's not policing. In fact, I'm helping because I'm surveilling. I'm helping by looking patients up in this database. But we can look at this and see, actually, you're not helping. What you're doing is you're turning these patients away. And if these prescription opioids were what was killing these patients, then you would be helping. But because you're turning them away, thrusting them out of the healthcare system, leaving them with nowhere to turn, or you're calling the cops on them, you're actually creating more harm than you would do it, frankly, if you just gave them the pill. And we can't fully blame pharmacists for that. They also are lacking, they're lacking other tools. Like, we had this huge crisis, and then we handed healthcare providers law enforcement surveillance tools instead of handing them more healthcare tools, more and better healthcare tools. Because I asked pharmacists, I said, look, you are the people who see people who are starting to develop a substance use disorder or who already have a substance use disorder. Do you have a way to help them get into treatment? Other than just turning them away, do you have anything else that would help them get access to care? And almost across the board, they told me no.
And of course, then the other thing is that there is a huge amount of evidence that has shown that the only way to treat these opioid habits effectively, when they are in fact completely abused, which is there's no underlying pain, which if there's underlying pain, it complicates everything. But if you're just hooked on the opioids, you need medically assisted treatment. And MAT programs, from an evidence perspective, please correct me if I'm wrong, but from an evidence perspective, are way out ahead of anything else in terms of effectiveness. But they are very under-resourced. There's very few of them. And more importantly, they weren't available at all when the prescription monitoring programs came out. So for a while there was a place where the effective treatments that we have today weren't available at all. So the only choice was essentially to kind of criminalize or not in many contexts. Am I right about this?
Actually, it's even more complicated than that. So remember how we were talking about sometimes you have these generic drugs that are really cheap and really accessible, and then you have newer drugs that are less cheap but are on patent. That's the case with methadone compared to buprenorphine. So both of those are medications for opioid use disorder. Both of them are extremely effective for treating opioid use disorder. Methadone is criminalized in its own way. Methadone is separated. Methadone, when used to treat opioid use disorders, is treated in what are called opioid treatment programs. They are separate from the rest of the healthcare system, and there too, patients are they are observed taking their medications. They have to go every single day to the methadone clinic. Can you imagine? I mean, think about. I mean, for people who are watching, think about taking the medication that you take for your high blood pressure. Now imagine that every single day you have to go, you have to drive probably pretty far from your house. You have to go stand in line first thing in the morning to get your medication. And you have to do that every single day of your life. They're not going to give you a bottle of pills to take home. Think about how that affects your ability to hold down a job, the way that you engage with your family, your ability to go on vacation. The ability to plan your life and the amount of control that you have over your life. And so methadone is really constricted in these opioid treatment programs, even though it's an incredibly effective medication for opioid use disorder. Now, the irony is that methadone is also used to treat pain. And when it's used to treat pain, it can be dispensed at the pharmacy. So it's a very strange legal regime. And there's a free methadone movement that is pushing against those opioid treatment programs and is trying to get methadone into pharmacies, which is where it's located in almost every other country, or almost every other Western industrialized country has methadone located in the pharmacy. And so we have this kind of strange system. And then there's buprenorphine, which is, its brand name is Suboxone. And Suboxone is a newer medication for opioid use disorder. And so that medication is effective, but methadone has been around forever, and then not forever, but for over 50 years. So it's been around for a really long time. And buprenorphine is a newer medication, and these are incredibly effective, but not enough doctors prescribe them. And increasingly, and this is a challenge, and it's something that I'm really hearing anecdotally, I haven't really seen larger studies on it, but I keep hearing from pain patients that doctors want to take them off of their opioid and put them on Suboxone. And unlike methadone, which is used to treat pain, Suboxone is really designed to treat opioid use disorder. So this is part of my newer study that I'm doing, but it does raise questions for me about why doctors are putting patients who are on the fentanyl patch or who are on, some opioid pill, why they're pushing Suboxone on them. And I think a big part of that has to do with Suboxone has like an anti-addiction mechanism worked in. I can't tell you all the details of it, but there's a difference between being an opioid agonist, an antagonist, a full agonist, a partial agonist. That gets really deep into the weeds. But I think buprenorphine stops certain brain mechanisms that methadone doesn't. And so that's all complicated. But there is something very interesting happening with all of them.
So, Dr. Chiarello, Liz, I would love to get in the weeds. I want to get in the weeds more. I want to talk more about all of these options, but I was aiming for a 15-minute interview. It's now been 50 minutes, and I want to ask you about the criminalization of marijuana, the criminalization of psychedelics. All of these questions that are related to pain, the use of ketamine for treating all these things. It seems like the underlying mechanisms of PDMPs are going to be problematic for more than just opioids. That in fact, these systems and the fact that they don't work together are problematic across the board. And every single one of these has a different legal context And I think I've gotten only halfway through your book. So I know for a fact I would like to spend 4 hours more talking to you, but I don't know that my audience wants to listen to 4 hours at once. So
Fair.
perhaps another time. But can I just thank you again for being willing to come on before the conference and to come on remotely and to promote your work. These are exactly the kinds of policy, technology, data, and healthcare all hitting at the same time. These nexus issues where it's very obvious that there's a patient right problem that you cannot understand without getting into the details of the technology, um, and the details of how people are using the technologies in ways that are unexpected, which I think is probably the central thing for your book. Again, the book is Policing Patients. You can look behind Dr. Chiarello there for another picture of the cover. By the time you're able to see this video, you can get it on Amazon. It is
even now, even right now, you can get it on Amazon.
Yeah, you can pay for
right this minute, wherever fine books are sold.
Wherever fine books are sold, or even bookstores that are not fine, but you can still get it.
Even just okay bookstores, any of them, really.
Exactly. Yeah. It's all over the place. And let me just say, if you are interested in the interaction of health tech, and health policy, and you have been concerned about the opioid crisis, it is the first place where I have seen a serious discussion from all perspectives, and one that incorporates the implications of this data stuff. I think it is now required reading in my book, which is a little bit embarrassing because I haven't finished the required reading. So I expect I'm just like many of your other students, Dr. Chiarello, so forgive me for that. But again, thank you for joining us. I really appreciate it, and welcome to Datapalooza.
Thank you so much for having me. This was a pleasure.